Question 1. A 6-month-old infant presents with a history of poor feeding for 2 days, listlessness, and has a significantly sunken fontanelle. Peripheral pulses are weak, capillary refill is 5 seconds, and blood pressure is normal for age. What type of shock is the infant most likely experiencing? A. Cardiogenic shock. B. Septic shock. C. Hypovolemic shock. D. Obstructive shock. Answer: C. Hypovolemic shock. This question tests the recognition of hypovolemic shock, particularly in an infant. The keywords poor feeding for 2 days, listlessness, and significantly sunken fontanelle clearly indicate severe dehydration, which is the most common cause of hypovolemic shock in infants. While weak peripheral pulses and prolonged capillary refill are signs of poor perfusion, the normal blood pressure suggests compensated shock. For example, severe gastroenteritis can quickly lead to this level of dehydration and shock in infants. Always look for fluid loss history and signs of poor perfusion even if blood pressure is initially maintained. Question 2. A 3-year-old child with a known history of severe asthma presents to the ED. The child is agitated, has diffuse wheezing, prolonged expiratory phase, and an oxygen saturation of 90% on room air. What is the most appropriate initial oxygen delivery device? A. Nasal cannula at 2 liters per minute. B. Simple face mask at 6 liters per minute. C. Non-rebreather mask at 10 to 15 liters per minute. D. Bag mask device with 100% oxygen. Answer: C. Non-rebreather mask at 10 to 15 liters per minute. This question tests the appropriate oxygen delivery method for a child in significant respiratory distress. The keywords severe asthma, agitated, diffuse wheezing, and oxygen saturation of 90% on room air indicate hypoxemia requiring high-flow oxygen. A non-rebreather mask at 10 to 15 liters per minute provides the highest concentration of supplemental oxygen to a spontaneously breathing child, which is crucial for improving oxygenation in severe respiratory distress. While a bag mask device can deliver 100% oxygen, it is typically reserved for children in respiratory failure or arrest. Always use the highest flow oxygen device tolerated when a child is significantly hypoxic. Question 3. What is the most common presenting rhythm in pediatric out-of-hospital cardiac arrest? A. Ventricular fibrillation, VF. B. Pulseless electrical activity, PEA. C. Asystole. D. Supraventricular tachycardia, SVT. Answer: C. Asystole. This question focuses on the epidemiology of pediatric cardiac arrest rhythms. The keyword most common presenting rhythm in pediatric out-of-hospital cardiac arrest is crucial. Unlike adults, where ventricular fibrillation is more common, children predominantly present with asystole or pulseless electrical activity, PEA, in out-of-hospital cardiac arrest, often due to a primary respiratory or circulatory failure leading to progressive hypoxia and acidosis. For example, a child who arrests from severe pneumonia is more likely to be found in asystole. Always remember that pediatric cardiac arrest is usually non-shockable in origin. Question 4. A 10-month-old infant is found unresponsive, apneic, and pulseless. There are 2 healthcare providers present. After initiating high-quality CPR, what is the correct compression-to-ventilation ratio for this infant? A. 30 compressions to 2 ventilations. B. 15 compressions to 2 ventilations. C. Continuous compressions with 1 ventilation every 6 seconds. D. 5 compressions to 1 ventilation. Answer B. 15 compressions to 2 ventilations. This question tests knowledge of basic life support, BLS, guidelines for infants during a teen resuscitation. The keywords 10-month-old infant, unresponsive, apneic, pulseless, and 2 healthcare providers are crucial. For 2 or more rescuers performing CPR on an infant or child, the recommended compression to ventilation ratio is 15 compressions to 2 ventilations to minimize interruptions in chest compressions while ensuring adequate breaths. This ratio helps ensure a balance between effective circulation and oxygenation. Always remember that the ratio changes depending on whether you are a lone rescuer or part of a team. Question 5. Which of the following is the most definitive intervention for relief of a tension pneumothorax in a pediatric patient? A. Chest compressions. B. Needle decompression followed by chest tube insertion. C. Bag mask ventilation. D. Endotracheal intubation. Answer B. Needle decompression followed by chest tube insertion. This question addresses the definitive emergency treatment for a tension pneumothorax. The keyword most definitive intervention for relief of a tension pneumothorax is key. A tension pneumothorax is a life-threatening condition where air accumulates in the pleural space, compressing the lung and heart. Immediate needle decompression is the emergency intervention to relieve pressure, but it is a temporary measure. Definitive treatment requires chest tube insertion to continuously drain air and allow the lung to re-expand. For example, a child with chest trauma who develops sudden respiratory distress and hypotension needs a needle decompression immediately, followed by a chest tube. Always recognize the need for both rapid decompression and definitive chest tube placement. Question 6. A 5-year-old child presents with a sudden onset of unresponsiveness and seizures after ingesting an unknown medication. On examination, the child has a heart rate of 50 bpm, wide QRS complexes on ECG, and hypotension. What is the most likely cause of this bradycardia and cardiac dysfunction? A. Hypoxia. B. Hyperkalemia. C. Tricyclic antidepressant, TCA, overdose. D. Beta blocker overdose. Answer C. Tricyclic antidepressant, TCA, overdose. This question describes a specific toxicological emergency causing cardiac dysfunction. The keywords unresponsiveness and seizures after ingesting an unknown medication, heart rate of 50 bpm, wide QRS complexes on ECG, and hypotension are highly suggestive of a tricyclic antidepressant, TCA, overdose. TCAs block fast sodium channels in the heart, leading to wide QRS complexes, myocardial depression, and conduction abnormalities, including bradycardia and hypotension. For example, if a child accidentally ingests antidepressant medication, these severe cardiac signs can develop rapidly. Always consider TCA overdose in a child with wide QRS complex bradycardia and neurological symptoms after an ingestion. Question 7. What is the recommended minimum systolic blood pressure, SBP, for a 7-year-old child to maintain adequate perfusion? A. 60 millimeters of mercury. B. 70 millimeters of mercury. C. 70 plus, 2x age in years, mmHg. D. 80 plus, 2x age in years, mmHg. Answer C. 70 plus, 2x age in years, mmHg. This question tests knowledge of age-appropriate normal blood pressure ranges in children. The keyword recommended minimum systolic blood pressure, SBP, for a 7-year-old child is crucial. A common guideline for estimating the minimum acceptable systolic blood pressure in children older than 1 year is the formula 70 plus, 2x age in years, mmHg. For a 7-year-old, this would be 70 plus 2x7 equals 84 millimeters of mercury. A child with a systolic BP below this threshold is considered hypotensive. For example, a 7-year-old child with an SBP of 75 millimeters of mercury would be considered hypotensive and in decompensated shock. Always use age-based formulas to determine normal blood pressure in children. Question 8. A 1-year-old infant is found unresponsive, not breathing, and has a weak central pulse of 40 bpm. A single rescuer immediately performs 30 seconds of high-quality positive pressure ventilation. The heart rate remains 40 bpm. What is the correct next step? A. Administer epinephrine 4/IO. B. Begin chest compressions. C. Check for a foreign body obstruction. D. Call for help/activate emergency response. Answer B. Begin chest compressions. This question tests the sequence of infant resuscitation by a lone rescuer. The keywords 1-year-old infant, unresponsive, not breathing, heart rate of 40 bpm, and heart rate remains 40 bpm after 30 seconds of high-quality positive pressure ventilation are critical. According to PALS guidelines, if an infant's heart rate remains below 60 bpm and they have signs of poor perfusion despite 30 seconds of effective positive pressure ventilation, chest compressions must be initiated. Epinephrine is considered after initiating chest compressions if the bradycardia persists. For example, if ventilation alone isn't bringing the baby's heart rate up, you need to start compressions. Always add chest compressions when symptomatic bradycardia persists despite adequate ventilation. Question 9. What is the preferred method for assessing the quality of chest compressions in real time during pediatric cardiac arrest in a hospital setting? A. Intermittent palpation of a central pulse. B. Visual assessment of chest recoil. C. Continuous quantitative waveform capnography. D. Measurement of blood pressure every 2 minutes. Answer C. Continuous quantitative waveform capnography. This question focuses on the most advanced and reliable real-time monitoring of CPR quality. The keywords preferred method for assessing the quality of chest compressions in real-time and hospital setting are crucial. Continuous quantitative waveform capnography, measuring EtCO2, is the preferred method because the EtCO2 value directly correlates with cardiac output during CPR. An EtCO2 consistently greater than 20 millimeters of mercury indicates effective chest compressions. Other methods are useful, but EtCO2 provides objective, continuous feedback. For example, if the capnograph shows a low EtCO2, it's a direct signal to improve compression technique. Always use EtCO2 to guide and optimize CPR quality. Question 10. A 4-year-old child presents with a sniffing position, severe inspiratory stridor, drooling, and is refusing to lie down. The child is agitated and febrile. What is the most appropriate initial management priority? A. Attempt direct laryngoscopy to visualize the vocal cords. B. Administer nebulized racemic epinephrine. C. Maintain a calm environment and allow the child to remain in a position of comfort. D. Initiate immediate bag mask ventilation. Answer C. Maintain a calm environment and allow the child to remain in a position of comfort. This question describes a classic presentation of severe upper airway obstruction, most likely epiglottitis. The keywords sniffing position, severe inspiratory stridor, drooling, refusing to lie down, agitated, and febrile are highly concerning. Any intervention that could further agitate the child or trigger complete airway obstruction, like direct laryngoscopy or forcing them to lie down, should be avoided. The priority is to maintain a calm environment, provide supplemental oxygen if tolerated without agitation, and prepare for a controlled advanced airway in an operating room with a surgical team. For example, don't try to look in their mouth or force them into a new position, just keep them calm. Always avoid agitating a child with suspected epiglottitis. Question 11. What is the recommended energy dose for the second defibrillation attempt for a child in ventricular fibrillation, VF? A. 0.5 J/kg. B. 1 J/kg. C. 2 J/kg. D. 4 J/kg. Answer, D. 4 J/kg. This question focuses on escalating energy doses for defibrillation. The keywords second defibrillation attempt and ventricular fibrillation, VF, indicate that the initial defibrillation attempt was unsuccessful. If the first defibrillation attempt at 2 J/kg fails to convert VF or pulseless ventricular tachycardia, private, the energy dose should be doubled for the second attempt to 4 J/kg. This increase in energy aims to provide a stronger electrical impulse to terminate the chaotic rhythm. For example, if the first shock doesn't work for VF, you would then deliver 4 J/kg for the next one. Always remember to escalate the energy for subsequent attempts if the first one fails. Question 12. During the disability component of the PALS primary assessment, what is the most common tool used to rapidly assess a child's level of consciousness? A. Glasgow Coma Scale, GCS. B. AVPU Scale. C. Pediatric Triage Tool. D. Cincinnati Pre-Hospital Stroke Scale. Answer, B. AVPU Scale. This question targets a specific assessment tool within the PALS framework. The keywords disability, component, and most common tool used to rapidly assess a child's level of consciousness are important. The AVPU scale, alert, voice, pain, unresponsive, is a quick and simple mnemonic used to rapidly assess a child's level of consciousness during the primary assessment. While the Glasgow Coma Scale, GCS, provides a more detailed neurological assessment, AVPU is faster for initial triage in an emergency. For example, a quick tap on the shoulder and call of their name can determine if they respond to voice. Always use AVPU for a rapid, initial assessment of mental status. Question 13. A 9-year-old child presents with a severe head injury from a bicycle accident. The child is unresponsive, has irregular respirations, bradycardia, and hypertension. This constellation of signs, Cushing's triad, is indicative of A. Hypovolemic shock. B. Spinal cord injury. C. Increased intracranial pressure, ICP. D. Status epilepticus. Answer, C. Increased intracranial pressure, ICP. This question describes the classic presentation of Cushing's triad, a critical sign of neurological deterioration. The keywords severe head injury, unresponsive, irregular respirations, bradycardia, and hypertension clearly point to Cushing's triad. This triad is a physiological response to significantly increased intracranial pressure, ICP, and indicates imminent brain herniation if not rapidly treated. It's a life-threatening emergency. For example, a child with bleeding in their brain from a trauma might develop these alarming vital sign changes. Always recognize Cushing's triad as a grave sign of elevated ICP. Question 14. What is the primary management goal for a child in compensated shock to prevent progression to decompensated shock? A. Maintain a low heart rate. B. Administer prophylactic antibiotics. C. Restore circulating blood volume and improve tissue perfusion. D. Administer sedatives to reduce agitation. Answer: C. Restore circulating blood volume and improve tissue perfusion. This question focuses on the main objective of treating compensated shock. The keywords primary management goal and compensated shock to prevent progression to decompensated shock are crucial. The body's compensatory mechanisms in compensated shock are already working hard to maintain perfusion, but they are finite. The primary goal is to address the underlying cause and aggressively restore circulating blood volume and improve tissue perfusion before these mechanisms fail, leading to decompensated shock. For example, if a child is dehydrated but still has a normal BP, giving fluids will prevent their condition from worsening. Always aggressively treat compensated shock to prevent deterioration. Question 15. A 6-month-old infant is found unresponsive with absent respirations and a heart rate of 70 bpm. A lone rescuer provides effective positive pressure ventilation for 30 seconds. The heart rate remains 70 bpm. What is the most appropriate next action? A. Begin chest compressions. B. Administer epinephrine 4/IO. C. Continue positive pressure ventilation. D. Reevaluate airway position. Answer: C. Continue positive pressure ventilation. This question tests a nuanced decision point in infant resuscitation. The keywords unresponsive, absent respirations, heart rate of 70 bpm, and heart rate remains 70 bpm after 30 seconds of effective positive pressure ventilation are critical. According to PALS guidelines, if an infant's heart rate is between 60 to 100 bpm and is showing signs of poor perfusion after 30 seconds of effective PPV, you should continue PPV and assess for other issues. Chest compressions are only added if the heart rate drops below 60 bpm. For example, if a baby is breathing better but their heart rate is still a bit low, but above 60, just keep helping them breathe. Always continue effective ventilation if the heart rate is greater than 60 bpm but still requires support. Question 16. What is the primary purpose of epinephrine in the treatment of pulseless electrical activity, PEA, during cardiac arrest? A. To convert the rhythm to a shockable rhythm. B. To increase myocardial contractility and peripheral vasoconstriction. C. To correct underlying metabolic acidosis. D. To decrease cerebral blood flow. Answer: B. To increase myocardial contractility and peripheral vasoconstriction. This question focuses on the specific pharmacological action of epinephrine in PA. The keyword primary purpose of epinephrine in the treatment of pulseless electrical activity, PEA, highlights its mechanism of action. In PEA and asystole, epinephrine's alpha-adrenergic effects cause peripheral vasoconstriction, increasing systemic vascular resistance and improving coronary and cerebral perfusion pressure. Its beta-adrenergic effects also increase myocardial contractility, potentially helping to generate cardiac output if any is present. For example, giving epinephrine helps push blood to the heart and brain even when the heart isn't beating effectively. Always remember epinephrine's role in improving perfusion during cardiac arrest. Question 17. A 2-year-old child presents with a barking cough, inspiratory stridor, and mild retractions. The child is afebrile and otherwise well. The most appropriate initial treatment is A. Oral antibiotics. B. Nebulized racemic epinephrine. C. Corticosteroids, e.g., dexamethasone. D. Humidified oxygen via face mask. Answer: C. Corticosteroids, e.g., dexamethasone. This question describes a child with mild croup. The keywords barking cough, inspiratory stridor, and mild retractions and afebrile and otherwise well indicate mild to moderate croup. While humidified air can help, corticosteroids, like dexamethasone, administered orally or intravenously, are the most appropriate initial pharmacological treatment for croup of any severity, as they reduce airway inflammation and swelling. Nebulized racemic epinephrine is generally reserved for more severe croup. For example, a dose of oral dexamethasone can significantly improve a child's croup symptoms within hours. Always remember corticosteroids as the primary medical treatment for croup. Question 18. What is a key consideration when selecting the size of an oropharyngeal airway, OPA, for a child? A. It should extend from the corner of the mouth to the earlobe. B. It should extend from the corner of the mouth to the angle of the jaw. C. It should be long enough to touch the epiglottis. D. It should be based on the child's weight. Answer: B. It should extend from the corner of the mouth to the angle of the jaw. This question tests the proper sizing of an oropharyngeal airway, OPA. The keyword key consideration when selecting the size of an oropharyngeal airway, OPA, emphasizes proper technique. An OPA should be measured from the corner of the mouth to the angle of the jaw. If an OPA is too small, it may not adequately clear the tongue. If it's too large, it can push the tongue back and obstruct the airway or cause laryngeal trauma. For example, holding the OPA next to the child's face helps you pick the right size. Always ensure the OPA is properly sized to avoid further airway obstruction. Question 19. A child in septic shock is receiving vasopressor infusions. Which specific vasopressor is generally considered first-line for cold septic shock, with poor cardiac output and high systemic vascular resistance? A. Norepinephrine. B. Dopamine. C. Epinephrine. D. Phenylephrine. Answer: C. Epinephrine. This question asks for the first-line vasopressor in a specific type of septic shock. The keywords septic shock, vasopressor infusions, and cold septic shock, with poor cardiac output and high systemic vascular resistance, are crucial. Epinephrine is generally considered the first-line vasopressor for cold septic shock in children because it has both alpha-adrenergic effects, vasoconstriction to increase blood pressure, and strong beta-adrenergic effects, to improve myocardial contractility and heart rate. For example, if a child in septic shock has cool extremities and weak pulses despite fluids, epinephrine infusion is often started. Always choose epinephrine for cold septic shock to improve both cardiac output and systemic vascular resistance. Question 20. What is the most appropriate action if a defibrillator is immediately available for a child in cardiac arrest with known ventricular fibrillation, VF? A. Perform 2 minutes of CPR before defibrillation. B. Deliver immediate unsynchronized shock, then continue CPR. C. Administer 0.01 mg/kg epinephrine, then defibrillate. D. Attempt vagal maneuvers. Answer: B. Deliver immediate unsynchronized shock, then continue CPR. This question focuses on the immediate management of a shockable rhythm when a defibrillator is readily available. The keywords defibrillator is immediately available and child in cardiac arrest with known ventricular fibrillation, VF, are crucial. If VF is confirmed and a defibrillator is immediately available, the priority is to deliver an immediate unsynchronized shock, defibrillation, without delaying for initial CPR. Early defibrillation is the most effective treatment for VF. For example, if the pads are already on and the monitor shows VF, you should shock immediately. Always prioritize immediate defibrillation for confirmed VF when the device is ready. Question 21. A 6-year-old child presents with a history of generalized tonic-clonic seizure lasting for 8 minutes and is still seizing. What is the most appropriate initial medication to administer for status epilepticus? A. Phenobarbital. B. Levetiracetam. C. Lorazepam (4/IO) or midazolam IM/IN/4/IO. D. Phenytoin. Answer: C. Lorazepam (4/IO) or midazolam IM/IN/4/IO. This question describes a child in status epilepticus, a prolonged seizure requiring immediate intervention. The keywords generalized tonic-clonic seizure lasting for 8 minutes and still seizing confirm the diagnosis. Benzodiazepines are the first-line medications for terminating status epilepticus due to their rapid onset of action. Lorazepam (4/IO) or midazolam IM, intranasal IN/4 or IO are commonly used to quickly stop the seizure activity. For example, a child seizing for more than 5 minutes needs a benzodiazepine to prevent further brain injury. Always administer benzodiazepines promptly to break status epilepticus. Question 22. In a child with a suspected head injury, what is the safest and most effective method for securing an advanced airway if intubation is required? A. Nasotracheal intubation. B. Blind oral intubation. C. Rapid sequence intubation, RSI, with inline cervical spine stabilization. D. Surgical cricothyrotomy. Answer: C. Rapid sequence intubation, RSI, with inline cervical spine stabilization. This question focuses on airway management in trauma. The keywords suspected head injury and safest and most effective method for securing an advanced airway are crucial. Rapid sequence intubation, RSI, is the preferred method for securing an advanced airway in critically ill children, including those with head injuries, as it minimizes the risk of aspiration and provides optimal intubating conditions. Critically, it must be performed with inline cervical spine stabilization to prevent further spinal cord injury if trauma is suspected. For example, a child with severe head trauma needs careful intubation while keeping their neck still. Always use RSI with C-spine stabilization for traumatic head injuries. Question 23. What is the primary indicator that a child in respiratory distress is progressing towards respiratory failure? A. Increased respiratory rate. B. Mild retractions. C. Altered mental status, e.g., lethargy, unresponsiveness. D. Persistent cough. Answer: C. Altered mental status, e.g., lethargy, unresponsiveness. This question asks for the most critical sign of worsening respiratory status. The keyword primary indicator, progressing towards respiratory failure, is crucial. While increased respiratory rate and retractions are signs of distress, an altered mental status, lethargy, irritability, unresponsiveness, is a late and very concerning sign in a child with respiratory compromise. It indicates that the brain is not receiving enough oxygen, hypoxia, or is being affected by too much carbon dioxide, hypercapnia, signifying that the child is tiring and their respiratory efforts are failing. For example, a child who goes from crying to being very sleepy and difficult to arouse is likely headed for respiratory failure. Always prioritize changes in mental status as a major red flag. Question 24. A child is in cardiac arrest. The team has established 4/IO access. Which of the following is an appropriate volume for a saline flush after administering medications through the 4/IO line? A. 1 to 2 milliliters. B. 5 to 10 milliliters. C. 20 milliliters. D. It depends on the medication. Answer B. 5 to 10 milliliters. This question addresses the practical aspect of medication administration during resuscitation. The keyword appropriate volume for a saline flush after administering medications through the 4/IO line is important. After administering medications, especially critical ones like epinephrine, through an 4 or IO line, a rapid saline flush, typically 5 to 10 milliliters, or more for older children/adolescents, is essential to push the medication quickly into the central circulation. This ensures the drug reaches the heart promptly. For example, after giving epinephrine through a central line, follow it with a quick push of 5 to 10 milliliters of saline. Always flush 4/IO lines after medication administration to ensure drug delivery. Question 25. What is the most important factor to prevent heat loss in a newborn or young infant during initial resuscitation? A. Administering warmed intravenous fluids. B. Covering the infant with a single dry blanket. C. Placing the infant under a radiant warmer and drying thoroughly. D. Avoiding placing the infant on a cold surface. Answer C. Placing the infant under a radiant warmer and drying thoroughly. This question focuses on thermoregulation in newborns and young infants. The keywords most important factor to prevent heat loss in a newborn or young infant during initial resuscitation are crucial. Newborns and infants are highly susceptible to heat loss. The combination of quickly drying the infant to prevent evaporative heat loss and placing them under a radiant warmer provides direct, active warming to maintain normothermia. This is a foundational step in neonatal resuscitation. For example, after a baby is born, they are immediately dried and placed under a warmer. Always prioritize drying and active warming for newborns and young infants. Question 26. When assessing for the presence of a pulse in an unresponsive, apneic infant, 1 year, which location is most reliably palpated? A. Radial artery. B. Femoral artery. C. Carotid artery. D. Posterior tibial artery. Answer B. Femoral artery. This question specifies the correct pulse check location for an unresponsive infant. The keywords unresponsive, apneic infant, 1 year are important. For infants, the femoral artery, in the groin, or the brachial artery, in the upper arm, are the most reliably palpable central pulses. The carotid pulse can be difficult to locate in infants due to their short necks. For example, if you suspect cardiac arrest in a baby, you would feel for the femoral pulse for no more than 10 seconds. Always check the femoral or brachial pulse for quick and accurate assessment in infants. Question 27. A child presents with altered mental status, poor peripheral perfusion, and a weak, rapid pulse. Blood pressure is within normal limits for their age. This clinical presentation is most consistent with which stage of shock? A. Decompensated shock. B. Obstructive shock. C. Cardiogenic shock. D. Compensated shock. Answer D. Compensated shock. This question tests the recognition of compensated shock in a pediatric patient. The keywords altered mental status, poor peripheral perfusion, weak, rapid pulse, but crucially, blood pressure is within normal limits, indicate that the child's body is still actively compensating for inadequate tissue perfusion. In compensated shock, a child's body will try to maintain blood pressure by increasing heart rate, tachycardia, and peripheral vascular resistance, often resulting in a normal blood pressure despite other signs of poor perfusion like cool extremities or prolonged capillary refill time. For instance, a child with gastroenteritis and dehydration might show tachycardia and slightly prolonged capillary refill but still have a normal blood pressure, indicating compensated shock. Always look for a fast heart rate and other signs of poor perfusion even if blood pressure is normal, as these are early warnings. Question 28. What is the recommended oxygen delivery method for a child in respiratory failure who is still breathing spontaneously but inadequately? A. Nasal cannula. B. Simple face mask. C. Non-rebreather mask. D. Bag mask device with 100% oxygen. Answer: D. Bag mask device with 100% oxygen. This question tests the appropriate oxygen and ventilation strategy for a child in respiratory failure. The keywords respiratory failure and still breathing spontaneously but inadequately are crucial. When a child is in respiratory failure, their spontaneous breathing efforts are no longer sufficient to maintain adequate oxygenation and ventilation. A bag mask device with 100% oxygen is necessary to provide positive pressure ventilation, PPV, to support or take over their inadequate breathing, preventing progression to respiratory arrest. For example, a child with severe pneumonia who is lethargic and taking shallow, slow breaths needs assistance with a bag mask. Always provide PPV with a bag mask for inadequate spontaneous breathing in respiratory failure. Question 29. A 4-year-old child presents with a history of choking on a small toy. The child is conscious, coughing forcefully, and able to speak. What is the most appropriate immediate action? A. Perform abdominal thrusts, Heimlich maneuver. B. Perform back blows. C. Encourage coughing and monitor closely. D. Prepare for immediate intubation. Answer: C. Encourage coughing and monitor closely. This question addresses the management of a mild foreign body airway obstruction. The keywords choking on a small toy, conscious, coughing forcefully, and able to speak are critical. These signs indicate a mild airway obstruction where the child is still able to move air. The most appropriate immediate action is to encourage them to continue coughing, as their own cough is often the most effective way to dislodge the object. Intervention, like abdominal thrusts, is reserved for severe obstruction where the child cannot cough effectively, make sounds, or becomes unresponsive. For example, if a child is coughing well after choking, just watch them closely. Always encourage effective coughing in a conscious child with a mild airway obstruction. Question 30. During post-cardiac arrest care, what is the primary goal for managing oxygenation to optimize neurological outcome? A. Maintain SpO2 as high as possible, 100%. B. Avoid hyperoxia, SpO2 greater than 94%, and hypoxia, SpO2 less than 90%. C. Maintain SpO2 between 88 to 92%. D. Aggressively hyperventilate with 100% oxygen. Answer: B. Avoid hyperoxia, SpO2 greater than 94%, and hypoxia, SpO2 less than 90%. This question focuses on optimal oxygenation targets in post-cardiac arrest care. The keywords primary goal for managing oxygenation to optimize neurological outcome are crucial. Both hypoxemia, too little oxygen, and hyperoxia, too much oxygen, particularly an SpO2 of 100% when not needed, can be detrimental to the brain after cardiac arrest. The current recommendation is to titrate oxygen to avoid both, aiming for oxygen saturation between 90 to 94%, or sometimes slightly higher, like 94 to 98% in some guidelines depending on context, but certainly avoiding sustained 100% oxygen when not clinically indicated. For example, after the heart restarts, you would adjust the oxygen flow to keep saturation in the ideal range. Always aim for a balanced oxygenation to protect the brain. Question 31. What is the recommended minimum frequency for performing defibrillation attempts during pediatric cardiac arrest with a shockable rhythm? A. Every 30 seconds. B. Every 1 minute. C. Every 2 minutes. D. Every 5 minutes. Answer: C. Every 2 minutes. This question addresses the timing of defibrillation attempts during CPR. The keyword recommended minimum frequency for performing defibrillation attempts is important. After the initial defibrillation and immediately resuming CPR, rhythm analysis, and subsequent defibrillation attempts, if a shockable rhythm persists, should occur every 2 minutes, interspersed with 2 minutes of high-quality CPR and drug administration. This allows for adequate CPR cycles between shocks to circulate medications and reperfuse the heart. For example, you would shock, do 2 minutes of CPR, then reanalyze the rhythm. Always ensure continuous CPR for 2 minutes between defibrillation attempts. Question 32. A child has a weak, thready pulse, prolonged capillary refill, and cool extremities. Despite receiving 220 milliliters per kilogram fluid boluses, these signs of poor perfusion persist. What is the next most appropriate intervention? A. Administer a third 20 milliliters per kilogram fluid bolus. B. Initiate vasopressor support. C. Administer calcium chloride. D. Insert an advanced airway. Answer: B. Initiate vasopressor support. This question describes a child in fluid refractory shock. The keywords weak, thready pulse, prolonged capillary refill, and cool extremities indicate poor perfusion. Crucially, despite receiving 220 milliliters per kilogram fluid boluses, these signs of poor perfusion persist, signifies that the child is no longer responding to fluid resuscitation alone. In such cases, vasopressor support, e.g., epinephrine, norepinephrine, dopamine infusions, is indicated to improve vascular tone and cardiac output. For example, a child with septic shock who doesn't improve after 40 milliliters per kilogram of fluid needs medication to support their blood pressure. Always consider vasopressors when fluid boluses are insufficient to improve perfusion. Question 33. A 1-month-old infant is severely agitated, has a high-pitched cry, and bulging fontanelle. The infant has a history of prematurity. What is a critical immediate concern? A. Hypoglycemia. B. Meningitis. C. Increased intracranial pressure. D. Hypothermia. Answer: C. Increased intracranial pressure. This question describes classic signs of elevated intracranial pressure in an infant. The keywords severely agitated, high-pitched cry, and especially bulging fontanelle are hallmarks of increased ICP in infants, who have open fontanelles allowing for some expansion. While meningitis could cause similar symptoms, elevated ICP is the direct physiological concern requiring immediate management to prevent brain damage. For instance, a premature infant is at higher risk for intraventricular hemorrhage, which could cause these signs. Always recognize a bulging fontanelle and high-pitched cry as red flags for increased ICP in infants. Question 34. What is the recommended energy dose for the second synchronized cardioversion in a child with unstable supraventricular tachycardia, SVT? A. 0.5 J/kg. B. 1 J/kg. C. 2 J/kg. D. 4 J/kg. Answer: C. 2 J/kg. This question focuses on escalating energy doses for synchronized cardioversion. The keywords second synchronized cardioversion, child, and unstable supraventricular tachycardia, SVT, indicate that the first attempt was unsuccessful. If the initial synchronized cardioversion at 1J/kg fails to convert unstable SVT, the energy dose should be doubled for the second attempt to 2J/kg. This increase in energy aims to provide a stronger electrical impulse to terminate the re-entry circuit causing the tachycardia. For example, if the first 1J/kg shock doesn't work for an unstable SVT, you would then deliver 2J/kg. Always remember to escalate the energy for subsequent attempts if the first one fails. Question 35. When checking for a pulse in an infant, how long should the pulse check take? A. At least 10 seconds. B. No more than 5 seconds. C. No more than 10 seconds. D. Exactly 15 seconds. Answer, C. No more than 10 seconds. This question addresses a critical time constraint during a pediatric resuscitation. The keyword, how long should the pulse check take, highlights the importance of minimizing interruptions to chest compressions if CPR is needed. A pulse check in an infant, or any age, should take no more than 10 seconds. If a pulse is not definitively felt within this time frame, or if the heart rate is less than 60 bpm with signs of poor perfusion, CPR should be initiated immediately. For example, quickly feeling for a brachial or femoral pulse for a count of 10 seconds helps you decide if CPR is necessary. Always aim for quick, efficient pulse checks. Question 36. Which of the following is an important initial consideration when managing a child with suspected electrical injury? A. Focus solely on treating burns. B. Administer prophylactic antiarrhythmics. C. Assess for cardiac arrhythmias and stabilize the cervical spine. D. Immediately administer large fluid boluses. Answer, C. Assess for cardiac arrhythmias and stabilize the cervical spine. This question focuses on the initial management priorities for electrical injury. The keyword initial consideration when managing a child with suspected electrical injury emphasizes immediate, life-threatening concerns. Electrical injuries can cause severe internal damage, including cardiac arrhythmias, even delayed onset, and significant muscle contractions that may result in spinal trauma. Therefore, continuous cardiac monitoring and cervical spine stabilization are critical initial steps. For example, a child who has been electrocuted may have an unstable spine from a fall or muscle spasms, and needs heart rhythm monitoring. Always prioritize assessing for and managing cardiac and spinal injuries in electrical trauma. Question 37. A child in diabetic ketoacidosis, DKA, presents with altered mental status and signs of dehydration. What is the most appropriate initial fluid management strategy? A. Rapid bolus of 20 milliliters per kilogram D5W. B. Slow infusion of 10 milliliters per kilogram 0.9% normal saline over 20 minutes. C. Rapid bolus of 10 to 20 ml/kg 0.9% normal saline over 15 to 30 minutes. D. Avoid fluid boluses due to risk of cerebral edema. Answer, C. Rapid bolus of 10 to 20 ml/kg 0.9% normal saline over 15 to 30 minutes. This question addresses a specific fluid management strategy for diabetic ketoacidosis, DKA, in children. The keywords child in diabetic ketoacidosis, DKA, and initial fluid management are critical. For children with DKA, rapid rehydration is essential. An initial fluid bolus of 10 to 20 ml/kg of 0.9% normal saline over 15 to 30 minutes is recommended to restore intravascular volume and improve renal perfusion. While there's a risk of cerebral edema with DKA, severe dehydration must be corrected first, but subsequent fluids are given more cautiously. For example, a child presenting with very high blood sugar and lethargy from DKA needs this initial fluid to stabilize. Always prioritize initial fluid resuscitation for dehydration in DKA, followed by careful rehydration. Question 38. What is the primary role of the team leader during a pediatric resuscitation? A. Perform chest compressions. B. Administer medications. C. Monitor the cardiac rhythm. D. Oversee patient care, direct team members, and make clinical decisions. Answer: D. Oversee patient care, direct team members, and make clinical decisions. This question focuses on the critical function of the team leader in a resuscitation. The keyword primary role of the team leader highlights their overarching responsibilities. The team leader is responsible for the overall management of the resuscitation, including continuous assessment of the patient, directing team members, making critical clinical decisions, and ensuring effective communication. They act as the central orchestrator of the resuscitation effort. For example, the team leader continuously assesses the child's response to interventions and directs who performs compressions, gives medications, or manages the airway. Always recognize the team leader as the central figure guiding the resuscitation. Question 39. In a child experiencing a severe asthma exacerbation, which finding would indicate impending respiratory failure? A. Wheezing throughout all lung fields. B. Persistent barking cough. C. Silent chest with minimal air movement. D. Mild intercostal retractions. Answer: C. Silent chest with minimal air movement. This question addresses a critical sign of impending respiratory failure in asthma. The keywords severe asthma exacerbation and impending respiratory failure are crucial. A silent chest, absence of wheezing or breath sounds, with minimal air movement in a child previously wheezing is an ominous sign, indicating severe bronchoconstriction and exhaustion of respiratory effort, leading to severely diminished airflow. This is a medical emergency requiring immediate aggressive intervention, including advanced airway support. For example, if a child with asthma goes from loud wheezing to barely making a sound while struggling to breathe, it's a sign they're deteriorating rapidly. Always treat a silent chest in an asthmatic child as an emergency. Question 40. A 2-year-old child presents after a submersion incident, drowning. The child is responsive but coughing and has difficulty breathing. What is the most important initial management? A. Administer antibiotics. B. Ensure airway and breathing support with supplemental oxygen. C. Induce vomiting to clear aspirated water. D. Rapidly rewarm the child to prevent hypothermia. Answer: B. Ensure airway and breathing support with supplemental oxygen. This question focuses on the immediate management of a child who has experienced a non-fatal drowning incident. The keywords submersion incident, drowning, responsive but coughing and has difficulty breathing, emphasize ongoing respiratory compromise. The most important initial management is to ensure adequate airway and breathing support, typically starting with supplemental oxygen, to address hypoxia and potential aspiration-related lung injury. For example, a child pulled from a pool who is coughing and sputtering needs oxygen right away. Always prioritize immediate respiratory support for drowning victims, even if they are conscious. Question 41. What is the recommended method to open the airway for an unresponsive child with suspected cervical spine injury? A. Head tilt chin lift. B. Selleck maneuver. C. Jaw thrust maneuver. D. Oropharyngeal airway insertion. Answer: C. Jaw thrust maneuver. This question addresses a specific airway maneuver used in trauma. The keywords unresponsive child and suspected cervical spine injury are critical. The jaw thrust maneuver is the recommended method for opening the airway in a child with suspected cervical spine injury because it minimizes neck movement, which is essential to prevent further spinal cord damage. The head tilt chin lift, while effective for most unresponsive patients, should be avoided in trauma until cervical spine injury is ruled out. For example, a child injured in a car crash needs their airway opened without moving their neck. Always use the jaw thrust maneuver if a neck injury is possible. Question 42. When should sodium bicarbonate be considered in pediatric cardiac arrest? A. Routinely, after the first dose of epinephrine. B. For persistent asystole unresponsive to all other measures. C. For prolonged cardiac arrest with suspected metabolic acidosis or specific etiologies, e.g., hyperkalemia, tricyclic antidepressant overdose. D. Never, as it has no proven benefit in pediatric cardiac arrest. Answer: C. For prolonged cardiac arrest with suspected metabolic acidosis or specific etiologies, e.g., hyperkalemia, tricyclic antidepressant overdose. This question tests the specific indications for sodium bicarbonate in pediatric cardiac arrest, as it is not a routine medication. The keywords "when should sodium bicarbonate be considered" highlight its restricted use. Sodium bicarbonate is generally not recommended for routine use in pediatric cardiac arrest but may be considered for prolonged cardiac arrest, pre-existing metabolic acidosis, hyperkalemia, or certain drug overdoses, like tricyclic antidepressants, where acidosis is a primary concern. For example, a child with kidney failure developing hyperkalemia and cardiac arrest might benefit from bicarbonate. Always use sodium bicarbonate judiciously and for specific indications in cardiac arrest. Question 43. What is a key characteristic of the Pediatric Assessment Triangle, PAT? A. It is a comprehensive, hands-on physical exam. B. It provides a rapid, objective measure of vital signs. C. It is a quick, visual and auditory assessment performed without touching the child. D. It determines the specific diagnosis of the child's illness. Answer: C. It is a quick, visual and auditory assessment performed without touching the child. This question focuses on the fundamental nature of the Pediatric Assessment Triangle, PAT. The keyword "key characteristic" requires identifying its core feature. The PAT is a rapid, non-invasive, visual and auditory assessment of a child's appearance, breathing, and circulation that can be performed in seconds from across the room, without touching the child. Its purpose is to quickly categorize the child's physiological state, e.g., respiratory distress, compensated shock, to guide immediate priorities. For example, simply observing if a child is playing, quiet, or crying, how they are breathing, and their skin color forms the PAT. Always use the PAT for a quick initial impression to determine how sick a child is. Question 44. A 7-year-old child with a known history of congenital heart disease, single ventricle physiology, is found unresponsive and pulseless. The PALS team initiated CPR. What is an important consideration during resuscitation for this specific patient population? A. Prioritize fluid boluses over medications. B. High doses of vasopressors are generally tolerated well. C. Maintaining systemic vascular resistance, SVR, is crucial to balance pulmonary and systemic blood flow. D. Defibrillation is contraindicated. Answer C. Maintaining systemic vascular resistance, SVR, is crucial to balance pulmonary and systemic blood flow. This question addresses specific considerations for children with congenital heart disease during resuscitation. The keywords: known history of congenital heart disease, single ventricle physiology, highlight a complex physiological state. For children with single ventricle physiology, maintaining systemic vascular resistance, SVR, within a narrow range is crucial to optimize the balance between pulmonary and systemic blood flow, which is vital for oxygen delivery. Too high or too low SVR can severely compromise their fragile circulation. For example, careful use of vasopressors or vasodilators may be needed to achieve this balance. Always remember that children with complex congenital heart disease require highly individualized and nuanced resuscitation strategies. Question 45. What is the appropriate management for an infant, 1 year, with a severe foreign body airway obstruction who is conscious? A. Abdominal thrusts. B. Chest thrusts only. C. A combination of 5 back blows and 5 chest thrusts. D. Continuous positive airway pressure, CPAP. Answer C. A combination of 5 back blows and 5 chest thrusts. This question specifies the correct intervention for a conscious infant with a severe foreign body airway obstruction, FBAO. The keywords infant, 1 year, and severe foreign body airway obstruction who is conscious are crucial. For a conscious infant with a severe FBAO, the recommended intervention is a sequence of 5 back blows, followed by 5 chest thrusts, until the object is expelled or the infant becomes unconscious. Abdominal thrusts, Heimlich maneuver, are not used in infants due to the risk of injury. For example, if a baby is actively choking on a small toy, this sequence is performed to try and dislodge it. Always use back blows and chest thrusts for choking infants. Question 46. A child presents with an unexplained fever, rash, and poor perfusion despite adequate fluid resuscitation. This suggests A. Anaphylactic shock. B. Early cardiogenic shock. C. Septic shock. D. Neurogenic shock. Answer C. Septic shock. This question presents a scenario highly indicative of septic shock. The keywords unexplained fever, rash, and poor perfusion despite adequate fluid resuscitation are classic components. In septic shock, the body's overwhelming response to infection causes widespread vasodilation and capillary leak, leading to poor perfusion that often becomes fluid refractory. The rash could be petechial or purpuric, further supporting a severe bacterial infection. For example, a child with suspected meningitis or a severe bacterial infection who remains poorly perfused after fluid boluses is likely in septic shock. Always consider septic shock in a febrile child with signs of poor perfusion unresponsive to fluids. Question 47. What is the primary method to prevent secondary brain injury during post-cardiac arrest care in a child? A. Aggressive hyperventilation. B. Maintaining blood pressure and oxygenation within normal limits. C. Inducing deep hypothermia for 72 hours. D. Administering prophylactic corticosteroids. Answer B. Maintaining blood pressure and oxygenation within normal limits. This question focuses on the crucial aspects of preventing secondary brain injury after return of spontaneous circulation, ROSCI. The keyword primary method to prevent secondary brain injury highlights the foundational elements of post-arrest care. Ensuring adequate cerebral perfusion by maintaining blood pressure and avoiding hypoxia, maintaining oxygenation, are critical to preventing further damage to the brain cells that were already injured during the cardiac arrest. For example, after a child's heart restarts, ensuring their blood pressure is stable and oxygen levels are good is vital for brain recovery. Always focus on optimizing oxygen delivery and perfusion to the brain in post-arrest care. Question 48. When assessing circulation, which finding would be most concerning for decompensated shock in a child? A. Tachycardia. B. Prolonged capillary refill time. C. Hypotension. D. Cool extremities. Answer: C. Hypotension. This question asks for the most concerning sign of decompensated shock. The keyword most concerning for decompensated shock points to the stage where the body's compensatory mechanisms are failing. While tachycardia, prolonged capillary refill time, and cool extremities are all signs of shock, including compensated shock, hypotension, low blood pressure, is the hallmark sign of decompensated shock and indicates imminent cardiac arrest if not rapidly corrected. For example, if a child's blood pressure drops, it signals a critical stage of shock. Always remember that hypotension in a child is a late and very serious sign of shock. Question 49. A 1-year-old child presents with a sudden onset of inspiratory stridor, mild retractions, and agitation. The child was playing with a small toy just before symptom onset. What is the most likely cause of their respiratory distress? A. Croup. B. Bronchiolitis. C. Foreign body aspiration. D. Anaphylaxis. Answer: C. Foreign body aspiration. This question presents a classic scenario for foreign body aspiration in a young child. The keywords sudden onset of inspiratory stridor, mild retractions, and agitation coupled with playing with a small toy just before symptom onset are highly suggestive of an object lodged in the upper airway. Croup typically has a barking cough, bronchiolitis is lower airway, and anaphylaxis would have more systemic symptoms. For example, if a toddler is playing with small objects and suddenly starts choking or develops stridor, think foreign body aspiration. Always consider foreign body aspiration in a young child with acute respiratory distress, especially after playing with small objects. Question 50. What is the primary goal of the check, call, compress sequence for a lone lay rescuer finding an unresponsive child? A. To perform advanced airway procedures immediately. B. To minimize interruptions in chest compressions and rapidly activate emergency response. C. To deliver rescue breaths before anything else. D. To diagnose the underlying cause of collapse. Answer: B. To minimize interruptions in chest compressions and rapidly activate emergency response. This question focuses on the core objectives of the initial response by a lone lay rescuer in a pediatric emergency. The keywords primary goal, check, call, compress, and lone lay rescuer are critical. The check, call, compress sequence prioritizes immediate recognition of unresponsiveness, rapid activation of emergency medical services, often after initial CPR for children, and the immediate initiation of chest compressions to provide vital blood flow. This sequence emphasizes speed and continuous compressions. For example, a parent finding their child unresponsive would first check responsiveness, call for help, or activate EMS, and immediately start compressions. Always remember to prioritize early, effective chest compressions and rapid activation of emergency response.